Hello, my name is Chris Owen, and I am pleased to welcome you to Unit 2 of Carotid Artery Disease. In this unit, I will review the clinical manifestations of carotid artery disease. I will also review the assessment and diagnosis of cerebral vascular disease. Individuals can have multiple clinical manifestations of carotid disease. A significant number of individuals have no symptoms. Atherosclerosis in the carotid artery is a condition that develops over time. If one of the carotid arteries has atherosclerosis, the other three arteries, ipsilateral carotid and vertebral arteries, have increased flow to compensate for the decreased flow. Patients can become symptomatic over time. Carotid disease is most often found on carotid duplex or other testing as an incidental finding. If a clinician notes a bruit, which is an audible sound associated with turbulent flow over the carotid artery, diminished or absent carotid pulses, or blood pressure variations, further non-invasive or invasive testing should be performed to examine these abnormal findings. Persons with asymptomatic carotid stenosis of 50% have a risk of stroke in the 1% to 2% range annually. Early detection can reduce mortality and morbidity caused by cerebral vascular disease. Transient ischemic attack, or TIA, is defined by the latest guidelines as acute neurological changes with symptoms that last less than 24 hours and resolve. TIA is a strong predictor of stroke. The risk is highest in the first weeks. Within 90 days of the initial TIA, the risk of stroke is 13%. At 5 years, 30% of individuals with the TIA are at risk for a stroke. It is a precursor to a stroke. Aggressive identification, risk factor modification, and ongoing follow-up is key for stroke prevention. Amaurosis fugax, or transient monocular blindness, is a temporary reduction in blood flow to the eye. It is associated with sudden loss of vision and is typically described as a gray or black shade coming up or down over the visual field. This is caused by atherosclerosis of the ipsilateral internal carotid artery. It can also involve ophthalmic artery embolism. The risk of stroke is elevated in people with amaurosis fugax. A stroke is defined as neurological deficits that persist greater than 24 hours. Based on the carotid or vertebral artery involved, the symptoms vary and will be discussed in subsequent slides. Treatment is aimed at timely identification of symptoms, seeking emergency care, giving thrombolytic therapy in appropriately screened patients, and identifying the artery involved and intervening if possible. Based on data discussed in the ECVD guidelines established in 2011, approximately 88% of all strokes are ischemic and 9% are intracerebral hemorrhages, and 3% are subarachnoid hemorrhages. The goal of identifying individuals with carotid disease is to prevent stroke. In the practice guidelines, extracranial atherosclerosis accounts for 15 to 20% of all ischemic strokes. As the degree of stenosis increases in the carotid beds, the incidence of stroke rises. This unit will focus on ischemic strokes. In terms of acute ischemic stroke, an individual must exhibit signs of neurological deficit that persist longer than 24 hours. Symptoms that last less than 24 hours are defined as TIA. 1/3 of all stroke victims have no warning signs prior to having a stroke. 15 to 20% of patients with ischemic stroke have carotid artery disease. Ischemia or infarction present differently based on the artery involved. Symptoms of a right carotid distribution TIA or stroke include left-sided weakness, left-sided paresthesia or sensory loss, left-sided neglect, abnormal visual spatial ability, monocular blindness in the right eye, or visual loss in the right visual field. Aphasia can be seen in left-handed or ambidextrous individuals, but is more commonly seen in people with a left carotid distribution, TIA, or stroke. There are two types of ischemic stroke. The first is an embolic stroke. This is where a blood clot or plaque fragment forms somewhere in the blood, becomes mobile, and travels to the brain. Once in the brain, the clot or plaque fragment continues to move until it is in a small enough artery to occlude blood. Sources for an embolic stroke must be found. As pictured above, emboli can become mobile. Another source of embolic stroke is atrial fibrillation. Early detection and management of atrial fibrillation with anticoagulant is imperative. A thrombotic stroke is one where there is significant disease located in the carotid bodies. This plaque formation attracts blood clots and causes complete or near complete blockage and a resulting stroke. Evaluation of an individual that has known or suspected cerebrovascular disease includes a complete history and physical examination. In obtaining the history, the provider should have the patient describe the neurological event. The following should be obtained. What were the symptoms at the time of the event from the perspective of the individual and anyone that was with him or her at the time of the event? Also, describe what was affected: speech disturbances, visual disturbances, motor weakness or paralysis, which side was affected, vertigo, syncope, confusion, possible memory loss. Timing of the event would include time of day, duration of symptoms, and if there have been more than one episode. On physical examination, the clinician needs to inspect, palpate, and auscultate. In terms of inspection, the clinician should complete a neurological examination to evaluate cranial nerves. If a patient has symptoms of amaurosis fugax, an ophthalmoscopic examination should be done. This exam will assess for retinal emboli. With palpation, the clinician is palpating the carotid arteries. Palpate each carotid separately. Carotids are located on each side of the neck between the trachea and the sternocleidomastoid muscle. The clinician is assessing for diminished or absent carotid pulses. Of note, the carotid should not be massaged during an assessment, as this can cause bradycardia or disrupt plaque. Assess the supraclavicular fossa for pulsatile masses. On auscultation, the clinician is listening for a bruit in the carotid area. It is a high-pitched murmur secondary to turbulent blood flow. This is assessed by palpating the carotid artery, then using the bell of the stethoscope, listening for a bruit when the person is holding his or her breath. A bruit is usually louder as you move up to the upper one-third of the neck in the area that the carotid bifurcates. Both carotids should be assessed. A bruit is a marker of disease, but is not a sensitive test to identify the extent or significance of disease. Based on the Framingham Heart Study, the incidence of stroke in patients with cervical bruit was 2.6 times than those without bruit. Of note, presence of a heart murmur may cause bruit that radiates to the neck. Blood pressure should be obtained in both arms to see if there is a difference. A significant difference is more than 10. This can be indicative of subclavian artery disease. The next step in the evaluation of a patient that has symptoms or is suspected of having carotid disease is a duplex ultrasound. Carotid duplex ultrasonography is the gold standard for assessing carotid stenosis. It is a non-invasive test performed in a vascular laboratory. Duplex combines images of structures in grayscale, and color blood flow is combined with Doppler signal. Color images combines anatomic and hemodynamic information. During a carotid duplex ultrasound, images of the common internal and external carotid arteries are obtained. Based on data obtained, stenosis is graded as 0 to 50, 50 to 69%, and 70 to 99% stenosis. If the results of the carotid duplex are inconclusive, then additional testing should be considered, including magnetic resonance angiography or CT angiography. MRA produces non-invasive images of the cervical arteries as shown in this picture. These images provide detailed assessment of the great vessels of the aortic arch and the extracranial arteries, and are projected like conventional angiogram images. There is a subset of patients that cannot have an MRI or MRA. Those individuals include patients with implantable devices like permanent pacemakers, ICDs, have profound obesity, and or are claustrophobic. Magnetic resonance contrast is used. However, these compounds are associated with a much lower incidence of nephrotoxicity and allergic reaction than angiography. Having an MRI or MRA requires that the patient lie very still while the images are obtained. Sometimes pre-procedure sedation can be provided. Computed tomographic angiography, or CTA, provides images of the aortic arch, great vessels, carotid anatomy, up to the circle of Willis. The advantage of CTA is that it can provide reliable data on arterial lumens and therefore can identify degree of stenosis. The limitation of CTA is that it requires the use of iodinated contrast media that put patients at risk for nephrotoxicity and allergic reactions. Conventional arteriogram of the carotid arteries. An arteriogram or angiogram is a special X-ray to examine the arteries. Contrast dye is injected into the artery, delineating the arterial anatomy, and is the definitive diagnostic study to determine arterial insufficiency when revascularization is planned. This can detect arterial stenosis or acute thrombosis of an artery. It is performed via an artery, generally radial, femoral, or brachial, being punctured by a cannula through which catheters, guide wires, balloons, and stents can be passed. This affords opportunity for the physician to perform endovascular treatment at the time of the diagnostic study, depending on the patient's renal function. Limitations include using caution in patients with renal insufficiency, since the iodinated contrast is metabolized through the kidneys. This concludes Unit 2 of carotid artery disease.